Greetings and welcome to another Oral Pathology Tuesdays. This is where we get together every week to talk about oral pathology, oral medicine, oral radiology, and basically all the diagnostic sciences of dentistry, and also to get to know each other and to connect. And today we have someone with us all the way from Japan, so it's an interesting and it's the first from that country, so just hold on. But in the meanwhile, also let me remind everyone it's the last week and the last time you will have a chance to win the free registration to the International Oral Diseases Case Presentation Conference 24. We will have our giveaway somewhere towards the end of the session or maybe in the middle. Just hang on so you can be there when it happens. Don't go away. And just to remind you, so what is the IODCPC? And you would know it's our third international conference, and it's all about cases, but we also do have keynote speakers, guest speakers. We have two lucky draws giveaway of books, which is really rare in a conference. One of those is the WHO Blue Book, and where you get access to all the 14 books because it is an online subscription. And the other one is the latest book on oral submucous fibrosis. And of course, we have 15 CDE points, and really, we have too much happening there. I'm not going to list all of it. Just if you're interested, register, and registration, please remember, will close at the end of this month. So you have only a few days to register. And this is the 3D venue just to see that it's a rather fun place to be. So you should join us. Now, with that, let me bring in our guest, Professor Tanaka. Welcome to our program, sir. It's really fun to have you here. And we did hear you in India before, just a few months back, but it's nice to have you here with us today. And let me give you a small background, a very short introduction, as always. Professor
Thank
Yoichi
you.
Tanaka, please, please go ahead. Yes, I think there is a little lag, Professor. Would you like to say something?
Yes. Mhm.
Okay, I will continue with the introduction. So, Professor Yoichi Tanaka is going to talk about reviving the role of oral cytology, basics of liquid based cytology. He has 43 years of experience in diagnosing head and neck lesions and general pathologies. His absolute expertise is in the field of cytology, which he's talking to us about. He has far too many publications and presentations to talk about. Let's just say he is definitely a very welcome expert in the field and globally well known expert in the field. And we are very happy to have him with us here. So let's watch the video as usual and come back for the discussion.
Good evening, everyone. Last November, I gave a lecture in India on an overview of oral cytology in Japan. I'm delighted to be able to speak again, this time from Japan, on oral pathology 360. This time, I will try to tell you a little more about the reporting format for oral cytology in Japan, which was created in 2015. In fact, in 2022, it was slightly reworked, but there was no major changes. This new reporting format was translated into the English in 2022. The new reporting form replaced the traditional Papanicolo classification and has four criterion for detection of oral squamous cell carcinoma. Oral cytology was developed based on the gynecology, so the Papanicolo classification is widely known. However, Papanicolo classification defines class 1 as absolutely benign, and class 5 was absolutely malignant. But the definitions of the intermediate class 2, 3, and 4 are unclear. Currently, there is a need to determine the nature of the cells and to classify them in accordance with the histological determinations. But it is unclear what to do next clinically. This new Japanese reporting format was designed for early detection of oral cancer in a dental clinic. The new reporting form was a 4 criteria. Also, when a report is received in a dental clinic, the dentist knows what to do next. We have created a video to show you.
The Oral Cytology Guidelines published in 2015 provide a reporting format based on the Bethesda system used for gynecological cytology. This classification differs from the traditional Papanicolaou classification, which is consistent with histological diagnosis. In categories OL-SOL and above, where tumorous lesions are presumed, referral to a higher-level medical institution is required. Dentists who specialize in cytology not only make the diagnosis, but also suggest what steps to take next, making the report easy to understand and meaningful to the general dental practitioner. First, nilum is a normal or reactive or benign lesion. At this stage, the main focus is on follow-up at the dental clinic. The comments on the test results also indicate that the patient requires observation. This is advice for the next step. This table shows response to nilum. OL-SOL is a classification that estimates low-grade intraepithelial neoplastic lesion. This intraepithelial neoplastic lesion is definitely considered to be a lesion that precedes invasive cancer. In the oral cavity, the detection at this time greatly affects the prognosis and requires measures to be taken at a higher-level medical institution. The test result report also conveys the seriousness of the condition and recommends close examination at a higher-level medical institution. OHI-SOL is a classification based on high-grade intraepithelial neoplastic lesions. It is a classification that requires a quicker response at a higher-level medical institution. The report also recommends immediate examination at a higher-level medical institution. And then there is SCC, a case that is clearly determined to be squamous cell carcinoma. This more clinically relevant classification also makes the content of the report more accurate in determining the future course of medical treatment. This table shows response to OL-SOL, OHI-SOL, and SCC.
This is the developmental pattern of oral cancer. In this photomicrograph, even though oral cancer is virtually invasive, keratinocytes are seen in the superficial layer. We call this type superficial differentiated. Most oral cancer are superficially differentiated type. This keratinocyte needed to look at carefully. I think the characteristics of these superficial keratinocytes make oral cytology difficult to determine. On the diagnostic side, the characteristics of this oral cancer must be known. So what core are collected in the oral extrapolative cytology? This is also explained in the video.
In oral cancer, most of the cancer cells generated from the basal layer show keratinization when they emerge on the surface. Hence, even if atypical cells proliferate and infiltrate in the deep layers, only the superficial keratinized layer can be visualized. This makes it difficult to make diagnosis by visual inspection alone. In oral cytology, the cells from this surface layer are collected.
So what are oral stain, OG stain cells and the light green stain cells mentioned in the video? We can imagine that the OG stain cells are keratinocytes. There are two types of the light green stain cells. One is a cell in the surface and the middle area just below the stratum coroneum. The other is a cell is a deeper layer that have the ability to proliferate. This is a pumpernickel stained frozen section of the normal oral mucosa. Exophylative cytology will collect the OG stained cell and light green stained superficial cell with scanned superficial ATP in the normal cases. Cytology shows the following image. Cytology shows the following impact. On the left OG stained cell with a poor ATP. Hyaluronic granules are also present, so some of the slightly increased immunocyte can be seen. On the right, the superficial light green stains, small, uniform nuclei with a normal endpoint C are seen. The judgment of the needle. In the early stage of cancer, apical cell, OG stain cells, and light green stain cells, as well as deeper light green stain apical cells are collected. You can see difference between compared to normal surface radial cells. OG atypical cells show a variety of the shapes, including large nuclei and thick cytoplasm with increasing luminosity. The judgment category for cytology is O high cell or SCC. Light green stain cells seen in a keratomatous ulcer, cluster of cells with large and small apical nuclei with increased amount of chromatin are present, together with generative necrotic materials. Slightly superficial light green stains with perinuclear halo are also seen in upper part. The judgment category for cytology is O high cell or SCC. It is important to note that both orange G stain cells and light green stain cells must be present for SCC to be a determinant. If there are few cells of either type or the other degree the ATP is low, then it should be O high cell. If the degree ATP is even low, O else is acceptable. In any case, a close examination at a higher level medical institution is required. In the malignant case, there is an increase in the brightness of the orange G cells and various nuclear ATP. And in well-differentiated SCC, you can see often atypical big cancer pearl. The diagram shows a schematic representation of what the epithelial pearl looks like. Epithelial pearl can be seen in both benign and malignant cases. The difference between the two are represented in the schematic diagram. Benign cells are small and have a concentric arrangement of the spindle-shaped cells. In a malignant case, they are large and often irregular, arranged with various type cells. The luminosity is also increased. When magnified, the atypical cells cluster is marked by numerous nuclei of the various size. In the cancer, cell connectivity is also reduced, so protruding cells are more prominent. Sometimes only light green stains are samples. They are more common in older people with atrophy epithelium. The item to be considered to be light green stains as shown. The degree of these items are taken into account of determining the degree of the light green stain cells. The more malignant cells cluster, the more advanced the diversity of its cells. If not determined, it's recommended to report to OLCL and to be determined by higher level medical institution. It's necessary to devise a way to carry out cytological examination in the dental clinic. LBC allows anyone to produce a clean specimen. This has helped to save clinical time and effort. Let's see the data from Tokyo Dental College. The collection method is LBC method. LCL and HCL were including the positive count of the SCC is hidden. There were a total of 170 cases with a historical diagnosis of SCC or dysplasia, of which 141 cases could be determined as LCL, HCL, or SCC by cytology. There was 33 cases of SCC and the dysplasia amount to those that were determined to be new. The sensitivity of the new reporting format is 81%. That false negative rate was 90%. The result of the Papanicolo classification is shown. In the Papanicolo classification, more cases of the SCC and the dysplasia were just negative than in the new reporting format. The sensitivity was 75.9%. The specificity 95.5%, and false negative rate 24.1%. The blue bar are a new reporting format, and the orange bar are for the Papanicolo classification. The new reporting form was high sensitivity, a low false negative rate, and a high false positive rate as compared with to the Papanicolo classification. This means that the new reporting format is more likely to be detected in the pickup, SCC, and the dysplasia than the Papanicolo classification. The new reporting format aimed to pick up superficially defined SCC and early cancer that and common in the early oral cavity. We consider this to be aligned to with the expectations. However, they are challenged with the new reporting format. The data is a bit old, but it shows a percentage of the positive diagnosis in decision categories. The result for NIRM or HISL and SCC are generally considered to be satisfactory. However, for OLCL, the average rate was 64%, although it rose to 89% in the 2017, leaving room for the improvement. For example, it was quite difficult to detect malignant changes in the leukoplakia by cytology. I will show you the histological and the cytological image. It takes a lot of skill to judge a light cytological image alone. We have identified OLCL because of the mild nuclear irregularity and increased luminosity, as well as the presence of the epithelial pearl on the right-hand side. In the oral cavity, the cell regenerative form basolateral cells which is similar to the deep atypical cells of the cancer. This means that it is more difficult to determine light-green stained cells. Light-green stained cells can be seen in both benign and malignant ulcers. When are differences between the both types of light-green stains? One of the key points of the differentiation is the presence of the keratinizing atypical cells. In other words, if keratinizing atypical cells were found in the cluster of the light green stain cell, it is malignant. This is malignant ulcer cell form of the well-differentiated squamous cell carcinoma. Somewhat atypical cell orange G-stained keratinocytes can be seen around the population of the large and the small light green stains atypical cells with poor connectivity. We have determined the keratinocyte to be OLC due to their rather weak ATP. As can be seen in the histological image of the light, the lower deep apical cells and upper keratinizing apical cells would be sampled. This is a light green stains of the population from a benign ulcer. Large nucleoli with well-defined nucleoli are present. We have determined that the nucleoli are almost uniform in the morphology and lack increase in the chromatin content. We judged it to be nil. It may be difficult to determine without the skill. The histological on the right shows the regenerative changes. The deep basal cells are continuous. The nucleoli are distinct, but the nuclei are approximately the same size. I have been in practice science or cytology for 25 years. In Ichika City, Chiba Prefecture, cytological diagnosis has been employed in the dental clinics for the oral mucosa examinations for past 18 years. Even now, about 500 cytological examinations are performed annually. Several cases of oral cancer are found every year, and early-stage cancer detection has increased. The patients were treated at the Oral Cancer Center of the Ichika General Hospital of the Tokyo Dental College. However, I believe that oral cytology is still in its infancy. There are same challenges for the future, such as the introduced of the virtual slide and AI. I hope we can collaborate with Indian oral pathologists to advance this project. If you have any questions, you can contact us by email. Also, please visit my official homepage. Thank you for your kind attention.
Thank you so much. That was really very interesting, Professor. And before we go on to questions, I have to remind everyone, please put in your questions and your comments in the chat. Before we go on, I would like to remind you, please type IODCPC24, hashtag IODCPC24 in the comments to become eligible for the draw. Now let's go to the questions. Yes. So I am not seeing any questions as yet. So let me ask one. So, are you regularly using cytology to diagnose cases? Professor, can you hear me?
No, yeah, okay. Yes, I used the oral cytology.
I think Dr. Hiller is in the process of typing a question. We will wait for him. And where do you find the best accuracy in the higher grades or in the lower grades?
Usually it's a low grade.
In the low grade, you better accuracy. Okay,
Yeah.
that's interesting. Okay, Professor Hiller has a comment. Congratulations on a most elegantly illustrated expose on oral cytology. This is a comment for you. Yes. I don't know if you might most likely know Professor Hiller, of course, but he is in South Africa and he does a lot of work on
Uh,
oral cytology himself.
oh, thanks.
Yes. We also
Yes.
have from Dr. Nandini, who even I was admiring your photomicrographs. They were really nice. And she's also saying the
Yeah.
photomicrographs are very nice. Anything else?
Thank you very much.
Everyone is appreciating your work. We have not reached any questions
Okay.
as yet. Professor Nasser from the US, he is also saying fascinating and informative. Okay, he has a question. What percentage of cases require confirmation with actual biopsy?
そういうことね。Usually, so you use make a diagnosis as a low L-cell and our high cell and SCC. It's always to make a diagnosis as histologically determined by the biopsy.
Okay. So
Can you
basically, we are
understand?
always going to follow up with a biopsy.
Yes, yes.
Okay.
It's only cytology is very dangerous, I think, especially as dental clinic, usually general dental clinic. It's
Yes.
possible to in a medical to higher medical institutions. It's only it's quickly to make a historical examinations. In Japan, generally in a dental clinic, it's impossible to do biopsy. It's necessary to determine to the higher level medical institutions.
Okay.
You understand? Okay.
So I guess more like most of the adjuvant tests we have now, it finally is more to tell you should you do biopsy or not. In the sense, if it's normal, you don't need to do a biopsy,
Hmm. It's
or would you
necessary
do
to
a
biopsy.
biopsy even for normal?
Yeah, normal.
Okay,
Mhm.
right. Okay. So we have another one is from Dr. Nandini. How do you differentiate regenerative change and dysplastic change in cytology?
Well, difficult to determine to the to regenerative change and well differentiated squamous cell carcinoma. But
Right.
this new reporting system is a pickup to the uh, oral mucosa, difficult to make a treatment in the general practice. For example, we make a diagnosis of OLC. It's pick up too easily to the early cancers.
Okay. OL was the second grade or the first grade. OL still
First,
is the lowest grade. The lowest grade, yes. Okay.
and me and some low-grade
It's low grade.
intraepithelial.
Yes.
Okay.
Okay.
I'm sorry.
New terminology. I have to get used to it.
Yes.
Right. Professor Hiller says, do you think that thoroughness of brushing influences the sensitivity of the results?
Yes, I think use the determine to the clinical taking the samples, same brushing use like a TEB.
Okay.
Yes,
We have another one
same
from Dr.
sample.
Naveed. He says cytology is interesting only for screening. For staging and depth of invasion treatment planning, incisional biopsy is considered gold standard. Yes, that's what just now also professor said. Yes. So any other questions? There seem to be questions there, but not here. Okay, right here it is. Dr. Krishna has a question. Can you elaborate on
Just
cytology in
yes.
vesiculobullous lesions? It's a
Brushing
question on
influence
vesiculobullous lesions.
creating red pairs. ああ、そうか。It's very difficult to cases difference between pemphigus like this. You know the pemphigus. I cannot. I understand in India there is how many much how many pemphigus cases. So in Japan, so usually to the increase to the pemphigus case. It's difficult to different paintings and repair cells.
Yes. Well, pemphigus here was not very much, but is slowly increasing. We are now seeing cases of pemphigus, even oral pemphigus. We are seeing more. Now, the question is either we are seeing more because they're actually increasing or that awareness is increasing and they approach doctors. That I cannot really tell you very well.
Yeah.
We have some of our colleagues who are into greater amount of practice here. They'll probably be able to comment. So, Professor Joss has another question. The transepithelial brushing TEB technique needs to be well understood by the clinician taking the sample.
Mm. It's very difficult questions. I think.
Yeah, this is, I think, more a comment actually rather than a question. Okay, Dr. Naveed is asking you the cost for doing the cytology.
Yeah. どのぐらいだろう。We use the LBC, liquid-based cytology. It's very expensive. But it's there is in Japan, life to insurance. It's this you use this system the about same cost.
Okay. So in Japan, basically, it is covered under insurance.
Yes.
That's nice. Many countries still don't cover anything dental and oral under insurance, sadly. Yes. Okay, Professor Hilla has a comment. I think it is about the regenerative change. Is they use streaming of LG stained cells as one of the criteria for repair. I think Dr. Nandini had asked, and I think that's her answer. Yes.
Yes.
And he also has a comment about the vesicular villus lesions. Pemphigus vulgaris is the only one that we can diagnose with confidence based on acantholytic cells. Very true.
Yeah.
Good one,
Yes.
yes. This, of course, Dr. Nandini, I think, is responding to Dr. Hiller, so let me read it anyway. So she is saying we can hardly get intact bulla in oral cavity in pemphigus. So cytology, okay. And Dr. Krishna. saying thanks a lot. Okay, lots of the Sindhi population. That's an it's a region of India have pemphigus. Okay, that's very interesting. Okay, I think we have for the moment finished the questions. Let's go and have the giveaway and then come back. Or do we have one? Okay, Professor Hiller basically is saying for this is again about the continuation of the uh, pemphigus. So you can brush adjacent mucosa of the ulcers or erosions. Basically, you're just supposed to essentially create your own bulla and then take it adjacent. Yes. Okay.
Yeah.
So let's do the giveaway and come back. Right. Everybody, please enter this IODCPC 24 for your lucky draw. Oops, what is this doing here? This was from the last time. My apologies. Okay. Right. So please start typing. And of course, from what I can see in the audience, almost everybody is. Yes, almost everybody is registered for the conference. So maybe you may find that the giveaway is not very helpful, but you can always give it to someone else. So please type and we will have our, well, lucky giveaway and then we will continue. So everybody can type, unless, of course, you all don't want it. Okay, nice. Thank you. Dr. Roy has already typed. Everybody else, please get in the action. Type. There is no harm in getting it. You can always give it to someone else. That will be nice. Yes. And in the meanwhile, you can also think of your last few. No, in fact, we have time. You can think of your further questions if you want. So, any more questions? Okay, there's a question. So, let's deal with the question also while we are waiting. Professor Hill has one question. Sorry, Hiller. I just want to get clarification on your interpretation of differentiated dysplasia versus non differentiating dysplasia. Oh my goodness.
Mm.
The elephant in the room. Okay. Yes, Professor Tanaka, that's the question we are taking now. I
Yeah.
hope you can read it. Yeah.
I think I think so. For me, it's very difficult to interpretation of the differentiation dysplasia and versus non-differentiated types. It's impossible to determine clearly. It's that occasions I make a diagnosis as low grade to intraepithelial neoplasm and a pickup to determine to the higher level medical institutions. But
Yes.
this system is for object to pick up in general dental clinic.
There's, I think, in the last Professor Joss will be able to tell us better. But I think sometime in the last year, or maybe in the new WHO book, this concept of differentiating dysplasia and has come
Uh,
up,
yeah,
and it
yeah,
is a little confusing. I have still not really read about it. I should begin to have a look. Maybe we should have a lecture on it now. It's about time we did have a lecture. And let me start this thing. Oops. Okay, it
yeah.
happened. Sorry, I wasn't really planning to do it as yet, but it did happen. Okay. And for some reason, it is only showing Krishna's name. That is not fair. No, okay, I'm going to run this again. Krishna, I'm very sorry for this, but I am going to have to run this again because, as you noticed, it did not show even other people's names. My apologies, my dear, but I am going to do this again. Just give me a moment, everyone. Let me bring a question for you all to tackle while I do that. Okay. There is, Professor Hiller says, we found that the uptake rate by dentists on oral
Uh,
cytology has been very slow.
mm,
And I guess there's a combination to that.
yeah,
Okay.
yeah.
To be very frank, Professor Hiller, is that the uptake is even very slow with oral pathologists too. Actually, I mean, let's not just blame the dentists. We ourselves, at least in India, we are very slow with accepting. Yes. So he has another one. He says, "How do you teach your students and colleagues?"
Hmm. Well, recently we make co-works in a student, especially the postgraduate student, to teach the oral cytology. That's the important techniques of the general practice. Can understand.
Sorry, sorry. No, no. That ignore what is happening on the stage there, please.
What?
Now let me bring you back here so you can. Professor Tanaka,
Yes.
yeah, ignore what is happening here at the same side with the names. You can deal with the question. This I'm just trying to correct that problem we had earlier.
What?
You
Uh,
can answer the question about how you teach your students and colleagues.
Uh, I have a network of the dentist and oral pathologist. Many received many questions from dental clinics,
Okay.
intimate correction and intimate to relationships, make relationships dental clinics.
So that always helps. Okay. Okay, now we are set to do this, so we shall do it. Sorry, now we will do the
Yeah.
giveaway. Sorry, I will interrupt you now for a minute. And this
Uh,
time, okay, I'm hitting this now, everyone. Be ready. All right, Sirisha,
What?
this was really yours. You won again.
Another advice,
Wow,
dentist.
wonderful, wonderful. Congratulations, congratulations, Sirisha. Okay, so please let me know who you want to give that registration to since I know you are registered. Okay, we will come back to our screen where we were having our discussion. Yes, we are back here.
Yeah.
Okay, so, uh, right. Professor Hiller has one more
Yeah.
question. Says, would you rather advise dentists in general practice?
Mm.
Okay, there's a different question. Would you rather advise dentists in general practice to refer patients for brushing for the cytology?
And I make so many to DVD. It's teach to the using my DVDs. I send the general practice
Okay, so you have made the recording and you send it. Okay, but that
and
can be difficult.
to sometimes I make to hands-on hands-on
Sorry.
seminars
Okay,
to
hands-on seminars.
towards general. Yeah.
Yes, that's also very practical. Yes, Sirisha. That was a bullseye. I am amazed that you actually won it the second time. This is where they say, where what is in your fate is in your fate, your destiny. No one can take it away, not even a piece of machinery. Okay, that was cool. Okay, any other questions, folks? We have for Professor Tanaka, and
Yes.
no other questions so far. Okay, I guess we can call it a day. Yes. Okay. Let us go to our certificate. Thank you so
I
much,
would like,
Professor Tanaka.
yes, I would like to connect by email about clearly the many questions.
Yes.
Thank you.
Anyone who wants Professor Tanaka's email, please get in touch with me and I will get you in. Yes. Okay. I think Professor Hiller read your mind and he's also asking for your details. I will share it. Yes. I can
Yes.
see that the two of you will have a lot to discuss and you have a lot to enjoy talking about. So, thank you so much for joining us and for bringing us this lecture. It was a great pleasure and hope you will come back again. Thank you so much.
Thank you.
And to tell everyone, this is normally when I share next week's event. I am thinking of actually bunking next week's event because I have too much of work setting up the conference. So, most likely, we will not have a OP Tuesdays on Tuesday, coming Tuesday, unless you all want me to talk to you about the platform or something like that. In which case, get in touch with me. If I have some requests, then I will do it. Otherwise, we will all meet at the conference in a short while. In the meanwhile, be well, be healthy, be well, be fine, be happy above all, and I will see you all in a little while in the conference. Bye bye, everyone.